How should skin be cared for after phototherapy treatment within the African American population? What products are best?
I can take this question. This is actually a great question, and it has an answer that's applicable to pretty much everybody, especially anybody with ongoing dermatologic conditions. Basically, what we want you to focus on is gentle skincare after your phototherapy sessions and between them. As part of phototherapy, there's always a risk of burning. You always can have some skin irritation. So I want you to focus on taking lukewarm showers. You don't have to shower every day. Use gentle soaps like Dove, sensitive skin type things. Moisturize when you get out of the shower. I do recommend a cream formulation. It's a little more moisturizing than just a lotion. Ointments are also great. Sometimes they get on your clothes and people don't like that. And that's kind of the basis of gentle skincare. And if you do sustain a burn during a phototherapy session, I would encourage you to talk to the dermatologist that's guiding your treatment and see if a low potency or mid potency topical steroid might be helpful in their opinion. But other than that, just over-the-counter products like CeraVe, Vanicream, Aquaphor, anything you can get at a general drugstore.
Can phototherapy completely eradicate the CTCL skin lesions? Roughly how long will the skin lesions recur after phototherapy?
This is a great question. And as the same theme that's come up multiple times, every patient with CTCL is different. So it is possible for patients to get excellent clearance of their skin lesions on phototherapy, but the duration for which you will stay clear can vary widely from patient to patient. I've seen patients who were treated in the 80s and stayed clear until they saw me now and needed retreatment with phototherapy. And I've seen patients that never get completely clear, and we have to consider other therapies to go with their phototherapy. So it's very hard to predict.
When doing phototherapy, should the whole body be treated or just those areas affected? Presently, the affected area is the back and torso and not the face and scalp.
In general, we treat the affected areas. Typically, we do some shielding of the face and the groin when we're doing phototherapy, unless those areas are specifically being treated. So you would treat the affected areas to the best of your ability.
Can going to the light box once a week be helpful in treating CTCL? I think that's one for
Lots of
Dr.
good light box questions. Yeah, so how often people get phototherapy is, again, a very individualized treatment. Oftentimes, we'll start with 2 or 3 times a week, and then once we get your disease under good control, we'll taper off. And some patients stay stable at once a week. Some people are able to go every other week. It really is person to person, and some people vary from season to season. So it's going to be kind of your body's choice in a lot of ways.
Is there an optimal amount of time for full body direct sunlight?
Well, that hasn't been formally studied in an objective study or trial. I can tell you what I recommend to my patients. So ultraviolet light, whether it's natural sunlight or in-office phototherapy, has a direct biologic effect on the cutaneous T-cell lymphoma cells in the skin, and results in them, dying off and going into remission. So patients with mild disease, natural sunlight sometimes can be very helpful. I usually tell patients 10 minutes of natural sun a day on a kind of average sunny summer day in Philadelphia without sunscreen. But if you're going to be outside more than 10 minutes, then you probably want to put sunscreen on your face and head and ears, and just monitor and be a little careful, because if you're out all day at the Jersey Shore, for instance, then you may get burned without sunscreen. So those are my recommendations.
So do you recommend photolight therapy as preventative treatment? How effective, and would you recommend it to younger patients who would be getting the treatment for a long period of time?
Today in 2024, we do not recommend that. I think many, many years ago, there was a bit of interest in that concept, but especially for young patients, if you get phototherapy week after week for many years, then you increase the risk of chronic sun damage and increase risk of skin cancers and melanoma. So long-term phototherapy for either prevention or as maintenance indefinitely, that shouldn't automatically happen. It is true that some patients, after they do phototherapy for their CTCL, if they had very difficult disease to control to begin with, then your doctor may recommend a slow taper and a maintenance regimen of once a week, once every other week. Sometimes for PUVA phototherapy, you can even do it once a month or once every 8 weeks. But those are selected patients, and your doctor will weigh all of the factors before they make that decision.
When we talked earlier about going out in the sun, should you be directing it mainly to the areas involved or the entire body?
Well, it depends. I would suppose if you have very limited, like just 1 or 2 patches, you could just expose those areas. The tricky thing about CTCL, though, is that it often then starts to, once it retreats from the areas being exposed, sometimes it likes to run and hide in the covered areas. So what I usually do is it depends on the patient's body surface area of patches and plaques, and also just what those patches and plaques are doing. Are they just sitting there? Are they moving frequently? But in general, when we actually prescribe in-office phototherapy, we recommend exposing the whole body because there is this tendency for the condition to start to travel to other areas that are being shielded from the light. But the face, because the face is usually not affected in most CTCL patients, if it is not affected, you can certainly shield your face and wear a hat. And, in the office, we shield the face with sunglasses and sometimes a pillowcase or a towel.
And another reason I think that sometimes we treat the whole body is that some skin lesions are not so obvious to the eye. And so you might notice that when you take a shower or do something that increases the blood flow through your skin, that you see additional lesions. And then as your skin cools down or your heart rate slows, the lesions become less visible. So if we just treat areas where there's obvious skin lesions, and there is what we would call like a subclinical, a skin lesion that you can't actually see so well with your eyes, but is there, and we don't treat it, then that would lead to you then over time seeing skin lesions in other areas and kind of playing whack-a-mole, having to go around treating all different areas because skin lesions are popping up.
Can you elaborate on the in-clinic or home therapy UV protocol? It's the first time they're hearing about oiling or creaming the skin first.
Oh, sorry about the background noise. So just to clarify, in the office, some patients do receive phototherapy without any pre-treatment oil or cream. And then the other offices do use the pre-treatment oil and cream. And it really depends on how scaly and how thick the scaliness of your lesions are. So there are some CTCL patients, if you have no flaking or scaling at all, then creaming and oiling before phototherapy, even at home, is probably not necessary. But if you have quite a bit of scale and it's thicker, then you should probably moisturize, not sunscreen, but regular moisturizer or oil to help the light penetrate better.
I think a common question people ask is what kind of oil? I always tell them it can be any oil. They could go in their pantry and use olive oil or baby oil. But what do you tell patients, Dr. Kim?
Yeah, I think I would absolutely agree with you. It doesn't have to be anything specific as long as it's not heavily fragranced. So definitely not some type of aromatic or botanical oil because there's often hypersensitivity to that.
I've been treated with UVB therapy with resolution of rash. Is it important to treat recurrent or new skin lesions that remain minimal? Does treatment impact long-term survival or have an effect on risk of transforming to a more severe stage? Excuse me.
Yeah, I think stage 1A, like we said, is an excellent prognosis. We don't have evidence to suggest that what we do, especially early on, will change what will ultimately happen. So I would say there's even evidence to say if it does minimally impact your life and it's very minimal disease, watchful waiting is a reasonable approach. That to say, just because we don't know it now doesn't mean we won't learn it in the future. that maybe treating does change things. But I think if it's minimal and it responds to phototherapy and this isn't too much of an impact on your life and you feel better treating it, it's reasonable to do it. If the treatment is impacting your life more than the disease, then you can also always consider watchful waiting with very limited disease like stage 1A.
Will phototherapy also be something we need as a forever treatment like Targretin, or is that something we can wean off of? Don't know who'd like to take a phototherapy question.
I'd probably prescribe more phototherapy for this condition than my oncologist. So it's very patient dependent and experience dependent, meaning a patient can undergo course of phototherapy and clear nicely in a matter of 3 to 6 months with 2 and sometimes 3 treatments a week, but I usually go with 2. I feel we can get there with 2. It may take a little longer. The doses are, slowly increase, so it can take time, and we want to do it safely. Patients who achieve remission with phototherapy, different centers will treat that patient differently. Some centers will have a philosophy that they want to keep the CTCL away and will do maintenance phototherapy. And I'm one of those physicians and at one of those centers where we have a long experience from Erwin Braveman to Richard Edelson, who have treated and started treating patients with phototherapy long before it was really understood as a therapy for CTCL. And so the way I do this is once a patient clears, we start to take a tapering approach. So we go to once a week, once every 2 weeks, once every 3 weeks, once every 4 weeks. And then I'll have some patients who go to phototherapy once a month and they get summers off and they'll stay clear indefinitely. Now, when's a good time to say, okay, let's throw caution to the wind and just stop? That's very much, again, a personal decision with the patient. For some patients, they'd much rather not want to have a surprise of seeing their lesions come back and then have to start from square one twice a week. And that's just, seems like very daunting for them. So they'll want to stay on maintenance. Other patients will be tired of even going to a phototherapy treatment center after years. But some of them do home therapy, and we help patients obtain boxes in their homes that insurance companies pay for. And so that can be very convenient and a way to really maintain and keep patients clear. So it does vary, but maintenance is my general rule.
I'm getting phototherapy. When can I use non-steroidal anti-inflammatory drugs?
Yeah, there's always concern when patients receiving phototherapy that medications that they take may make them more photosensitive and can result in a phototoxic or burn reaction in phototherapy. NSAIDs is on that list, and it's possible that will increase the sensitivity. In general, you take it after your treatment. It'll help calm some of the potential side effects and it won't make you photosensitive. It's not a very photosensitizing category of drugs. So, in general, it does vary patient to patient, but my recommendation is don't take such medications right before. The bigger concern is really along the lines of antibiotics. Some of those are very photosensitizing, in particular, the cyclins like doxycycline. That should never be taken prior to any phototherapy exposure. Even low doses for acne can be very sensitizing, for example. But most of the time, we'll see doxycycline prescribed for a staph infection, and a patient should make the treatment centers fully aware of any medications they're on, any new medications they might be taking before they get in a light box.
I'm a male doing phototherapy with athletic support. I have some itching and redness in my groin area. Is it safe to do phototherapy without anything on to treat my groin area?
Great question. So treatment centers will vary their recommendations on what to protect. In general, CTCL, mycosis fungoides, likes to appear in photoprotected areas. So, a jock strap can be plus because it's minimally protecting an area that can be very sensitive, but it can also have drawbacks in that if CTCL involves the scrotal or penile area, that it's not going to get treated with the light. So that needs to be really discussed with your physician, in particular dermatologist who might be examining you very closely in that area, and make a decision. Sometimes we do a very short part of phototherapy exposure without any protection there, to really allow the treatment to occur in an area that you might be protecting otherwise. But you can't just take it off when you've already had your dose ramped up, because that can result in a very severe burn. So communication and clarification around that. There are other things that make the groin itch too, so you need to be checked out for fungal infections, intertrigo, and these kind of things that can be treated with creams, and maybe that is the problem with the itch. The other thing with athletic supporters or jock straps is the straps. They can be very disconcerting in someone receiving phototherapy because they don't always necessarily line up in the same place. So when it slides slightly up or down, you can get a burn in some of those areas. So be very careful with that. Some of my patients have been very creative in using a handkerchief and a very loose Band-Aid for male genitalia protection. So, or a sock that fits just right. So there are people who can be creative in that way. It could be discussed at each treatment center. I work with a lot of treatment centers. We have one of the largest ones at Yale, and we make our recommendations, but it does vary treatment center to treatment center. Just because I do think it's really worth mentioning, one of the biggest mistakes I see is patients not taking their underwear off. Because again, buttocks, thighs, suprapubic area, very, very common areas for mycosis fungoides. But, there's kind of this natural reaction of people to keep their underwear on. But for the most part, we're treating your entire skin with phototherapy, save for a little bit of photoprotection in some sensitive areas.
Will narrowband UVB therapy stop or slow down the progression of my early patch stage MF? And what are the treatment goals for this therapy? Good question. Anyone?
I think that the treatment goal of any therapy of mycosis, I explain to my patients very frequently, we cannot cure mycosis fungoides usually. So our plan is not to cure you, but to keep you as less lesions as possible and as good quality of life as possible. And I would like, I think that maybe you can die in 40 years time or 50 years time because of a drone of Amazon falls into your head, maybe with patches on your skin, but not because of your patches of your skin. So in this case, patients relax and are aware that something that Rudy mentioned, that is very frequently the history of the disease is very prolonged, 20 or 30 or more years. So,
Right.
So most patients mix the term cure to free of disease.
Mm.
And what is our goal of all physicians who are dealing with cutaneous T-cell lymphoma and also other diseases, to keep the patient free of disease. Cure is a very high term you can have as a child if you have chills, but in the elderly you get zoster again when the immune system doesn't remember the virus. So this we have to discern and to explain the patient. We will keep you long-term free of disease. That does not mean you are cured.
Mm. After reaching 300 sessions of phototherapy, what would be the best approach if the patient still needs treatment at stage 1A? So I guess, what's the approach on phototherapy in early stage disease? Do you take a break? Do you continue? Do you have maintenance? Like what is that over that long-term treatment period, like years and decades? And thoughts on that?
Yes, I can answer or try to answer. Nowadays we don't have any more PUVA worldwide because toxicrotrolane is not anymore available. So we are concentrating of narrowband UVB. And one of the most principal, what I always told physician colleagues who doing phototherapy is not to increase the dosage. Because what we know from our experimental work from the past, let's say it's always 30, 40 years back, it's that the antigen presentation from the Langerhans and dendritic cells in the epidermis towards the lymphocytes is only depending on a few millijoule of energy to block this. So you don't have to increase constantly the dosage. And by increasing the dosage over time, over years, you increase the risk of secondary cancer. And that is a concern, what patients and we are as physicians and responsible for the patients have. So if you do it low dose, narrowband UVB, you can go a long time for the patients. And then you have to think intelligently during the key summer months. These patients can use with sunscreens the outdoor situation, if it is, and then start in autumn back to use once a week or 2 times a week, depending on the response, this UVB treatment over the winter time and until spring, and then stop and so on. And so you can continue over years with this very important UVB therapy for the patients.
I would like to comment. You mentioned the one patient asking about the stage 1A. The stage 1A means less than 10% of body surface with the patches and plaques. And there is one possibility, is not treatment at all. So it's not mandatory to treat the patient with stage 1A. This does not mean to discard the patient and to say you don't need to come back any longer, but you have to have control of the patient, see the patient regularly, explain very good the alarm problems if the lesion expands, the lesion expands into more than 10% of body surface area involved, or tumors or lymph nodes or whatever. But it's not mandatory to treat the patient with less than 10%. You have to explain the patient. Some patients say, I don't want to see any patch on my skin, and you treat. But there is no real need. We all agree about that. I think that we all agree about that.
Great. Oh.
But
we also do the same. We just treat during if the patient are suitable for phototherapy, we treat it during the winter, and then we advise to go to the sun in the summer. And I agree with Rudy. If we use low dose, we don't have to exceed millijoules, several millijoules to get a result, because we can get a result with low dose of narrowband UVB. And sometimes if the patient is willing to come to the hospital, then we reduce the frequency of the treatments, but other times we just continue with topicals. So yeah, this is the regime of treating.
Professor
Yes.
Stadler?
I have one point. We have in our guidelines, in the US guidelines, European guidelines, wait and see policy. It's also mentioned for stage 1A. However, due to what we saw in molecular investigations is that even in patients with stage 1A, there can be very dramatic molecular changes already. So if you think about fire in the US, so you have to distinguish even a small fire in California to prevent the spread over the northern part of California. So what I mean with this is just extinguish the fire. The fire means the initial CTCL that the clones are not able to expand. That's one notion. And of course, you have to balance. If you harm more the patients, and you help the patients with the disease. But in my experience over all these decades, it's better to extinguish every lesion you see, that patients feel free of any signs of CTCL. So they are free of disease.
Do we have any statistics or data? I probably know the answer to this to a degree, but on the number of people who have cutaneous T-cell lymphoma who are using sunlight alone versus more formal narrowband UVB? That's a really interesting question.
I could want to take a stab. I think it's a terrific question, and I think that while the answer, I'm pretty confident, is probably no in terms of we don't have great data in terms of survey data. It is a very hot topic, it's a very relevant topic, because we know that, well, phototherapy has been around for a long time, and it's been one of the very helpful treatments for now in CTCL. Number two, it's been around for a long time, it's been an effective treatment for other skin conditions. Number three is we're also unfortunately running into the logistic challenges that not everybody can go to the booth 3 times a week and for a couple of months. And we run into insurance and logistical challenges and home booths and that. And so what happens is undoubtedly a lot of patients, and we know this from our patients, go and they get some natural sunlight. And I think that in our discussions with the patients, I think it's a viable option. It's always do no harm. We can't cause harm. We don't want people to burn. But with discretion, it can be very useful. We joke with the patient, we have to abide by decency laws in certain parts and how much we can expose, in the region. But with discretion, it can be useful. And I think, Dr. Mo and I have seen that with our patients.
What are the risks of long-term UV treatment? UV treatment 2 minutes times once per week works well to prevent reoccurrence of my rash, but I wonder about long-term risks of UV.
So UV treatment, I would consider to be one of the safer methods for treating cutaneous lymphoma, as well as other skin conditions. It is UV, so there is potentially a small risk that if you are someone who's had a lot of UV damage to your skin over years and years of your life, there could be a theoretical increased risk in non-melanoma and melanoma skin cancers. But again, the dose is very controlled with narrowband UVB. It's supervised by a physician, and of course, using the treatments for only as long as you need to, and will kind of help mitigate your risks over time. From what you are telling me, a few minutes once a week for maintenance, that sounds fairly reasonable in terms of risk. But again, sort of everyone's history is a little bit different. And so just discuss with the clinician whether or not continuing UVB for indefinite periods of time is still appropriate for you, or whether, taking a break from treatment would be a good idea.
What are the thoughts on natural sunlight exposure on the affected area? Will that help get rid of the symptoms?
I think, yeah, a lot of my patients do feel that natural sunlight exposure can be helpful. It's similar to, it's the UV radiation essentially that you are getting if you were to go for phototherapy. And a lot of my patients have found it helpful if they don't have ready access to a dermatology office that has a phototherapy box, for example. Downsides, though, of natural sunlight therapy compared to UVB is sunlight, it's the full spectrum of UV radiation that you're getting. So other damaging UV radiation may then increase your risk of skin cancer, whereas with UVB phototherapy, it's a specific wavelength that acts against the immune cells in your body, so the risk of the exposure to the entire UV spectrum is much, much less. There's also a little bit less control or fine tuning of how strong of a dose you are getting with natural sunlight. So if you're someone who's at risk of sunburning, that's probably going to go up if you are trying natural sunlight over phototherapy, which the dose is much more controlled when you're in an office. So while there are some pros to getting some natural sunlight, it certainly can be helpful for helping with the itching, the redness, maybe just the lesion activity. You have to consider the downsides too when subjecting yourself to overall sunlight therapy for your body.
I've been doing light therapy for the past year. I found that continuous sessions, 2 to 3 times per week, have improved infected areas. But when I stop for a few weeks, I notice other areas become worse that were not as bad before. Can initiating light therapy without maintaining a consistent regimen adversely accelerate the condition? Or any other information you can provide regarding light therapy, frequency, and long-term effects?
So regarding whether or not light therapy can actually accelerate your condition, no, I don't believe there is data to suggest that light therapy actually worsens the condition. Many times, light therapy does take several months for it to demonstrate efficacy, and having it sort of tapered off or weaned off in a much more gradual manner does allow you to keep disease under control for much longer than if you were to just go for short periods of time. I think starting at 2 to 3 times weekly, as you've been doing, is very appropriate. And typically, I have patients continue that for at least a couple of months until it looks like they're getting some sort of a response. And then weaning off slowly, dropping frequency to twice a week, and then maybe once a week eventually until we can completely stop the light therapy. But even then, there are times where small individual spots will come back, where there's just a stubborn area that maybe is more shadowed by the light therapy that is not getting as much light dosage as the rest of the body. And in that case, other local therapies like topical steroids can then be used to address those particular stubborn areas.